All right, so today we're tackling two types of heart attacks that are, well, they're sneaky. They love to hide from a standard EKG. And here's the thing, missing them, that can be catastrophic. But knowing how to spot them, that is a skill that will absolutely save lives. So, let's get right into it.
So let's set the scene. We're in the ER, and a case comes in that's a real head-scratcher. You'll see what I mean.
Okay, picture this. A 62-year-old guy gets rolled in. He's clutching his chest, telling you it feels like it's being crushed. You know, that classic description. He's sweaty, he's nauseous, he just looks awful. Your gut tells you right away, this is the real deal.
So you throw him on the monitor and get vitals. And whoa, his blood pressure is way down at 85/60. And his heart rate? It's slow, only 58. He's bradycardic. But here's where it gets really weird. You listen to his lungs, they're totally clear. But you look at his neck, and his jugular veins are just popping out. That combination of low blood pressure, slow heart rate, clear lungs, and JVD, man, that should be setting off alarm bells like crazy.
Of course, you get an EKG stat. And sure enough, there it is, ST elevation. You see it in leads II, I3, and AVF. Okay, easy peasy, right? That's an inferior MI. Diagnosis made, let's move on. Or maybe not?
Yeah, hold on a second. Let's think about this puzzle. If his heart attack is so bad that his pressure is in the tank, shouldn't fluid be backing up into his lungs? I mean, that's what we'd expect in cardiogenic shock, but they're clear. So why? This question right here is the key to cracking this whole case.
To figure this out, we've got to talk about one of the biggest limitations of our go-to tool, the standard 12-lead EKG. Don't get me wrong, it's an amazing instrument, but it's not perfect. It has some huge blind spots.
So take a look here. The standard leads, they give us a pretty good picture of the front, the side, and the bottom of the left ventricle. But what's missing? Think about it. We're not getting a direct view of the right ventricle at all, and we're definitely not seeing the very back of the heart, what we call the posterior wall.
And that, right there, is the whole point. Some MIs are basically invisible to a standard EKG. They're hiding in plain sight. You will not find them unless you're suspicious enough to go looking for them.
Okay, so let's unmask that first hidden heart attack, the right ventricular MI. And you'll see it's the perfect explanation for what's going on with our patient.
Remember that triad from our patient? Hypotension, clear lungs, and high JVP. Well, that's the classic textbook sign for an RVMI. And it makes perfect sense, right? You've got hypotension because the sick right ventricle just can't push blood forward. The lungs are clear because the traffic jam is before the lungs. And the JVP is high because all that blood is backing up into the body's venous system. It's a perfect storm.
So here's your game plan. This is what you need to do every time. 1. You spot an inferior MI on the EKG. That's your trigger. 2. Your brain immediately has to think, could the RV be involved? Especially if you see that clinical triad. And 3. You don't just guess, you prove it. You go and place some right-sided leads. And it's super simple to do. You just take those chest leads and put them in the same spots, but on the right side of the chest. The money lead here, the one you really care about, is V4R. It sits right over the right ventricle. If you see ST elevation in V4R, boom, you've just diagnosed an RV infarct.
Okay, so why do we care so much? Because the treatment is the complete opposite of a normal MI. And messing this up is, well, it's really, really bad. Normally, for an MI, we give nitrates, right? But with an RVMI, that right ventricle is what we call preload dependent. Think of it like a rusty pump that needs a lot of water pressure to even get going. Nitrates will drop that pressure, that preload, and the patient's blood pressure will just plummet. So rule number 1, absolutely no nitrates. Instead, you give them IV fluids to boost that pressure.
All right, here's a pro tip for your exams, and honestly for real life. When you're looking at that inferior MI, check out leads 2 and 3. If the ST elevation in lead 3 is bigger than the elevation in lead 2, that's a huge clue that the right coronary artery is the problem. And since the RCA supplies the RV, well, your suspicion for an RVMI should go through the roof.
Okay, so that's the right side of the heart. Now let's swing around to the back and talk about the other big EKG blind spot, the posterior MI.
So, new patient, same complaint, chest pain. You get an EKG, but this time you see ST depression in leads V1 and V2. Now, what does everyone think? Oh, it's just some anterior ischemia. But what if it's not? What if that's actually a full-blown STEMI, just hiding on the back of the heart?
This is where you have to put on your mirror image thinking cap.
See, leads V1 and V2 are on the front, and they're looking through the heart to the back wall. So an ST elevation happening on the posterior wall looks like an ST depression from the front. And a Q wave back there, which means cell death, looks like a big, tall R wave from the front. It's just a reflection.
So, the algorithm is pretty much the same. Step 1. You see ST depression in V1 and V2. Step 2. Your brain doesn't just stop at ischemia. You have to think, wait, could this be a posterior MI in disguise? And step 3, you go prove it by placing posterior leads.
And here's how you do it. You just keep wrapping the leads around the patient's back, placing V7, V8, and V9. These guys sit right on top of the posterior wall. And if you see ST elevation in those leads, bam! You just found the hidden MI. You've confirmed a posterior STEMI.
Okay, so now that we're armed with all this knowledge, let's go back to our first patient and solve that puzzle.
So let's run through it. We had the inferior MI, that was our Q. We saw the classic triad, low blood pressure, clear lungs, big JVP. So we did the right thing. We slapped on a V4R. And sure enough, we saw ST elevation. Diagnosis, locked in. Inferior MI with RV involvement.
And because we nailed the diagnosis, we knew not to give him nitrates, which could have been a disaster. Instead, we pushed IV fluids. That gave his struggling right ventricle the preload it was starving for, and just like that, his blood pressure started to come up. We made the right call, all because we knew where to look for that hidden MI.
All right, let's boil this all down. What are the absolute must-know, high-yield takeaways here?
Okay, here's the quick and dirty summary. RVMI, you see an inferior MI plus hypotension, get that right-sided EKG, look for ST elevation in V4R, and for the love of all that is holy, avoid nitrates and give fluids. Got it? Good. Posterior MI, you see ST depression in V1 and V2, suspect it's a mirror image, get posterior leads V7 to V9, and look for that ST elevation. Oh, and keep an eye out for those tall R waves.
Look, if you remember absolutely nothing else from this, remember this one golden rule. When you see an inferior MI, that's your trigger. It's a huge flashing sign that there could be trouble with the right ventricle or the posterior wall. So every single time you see an inferior MI, you have to check for the other two. Because at the end of the day, the most dangerous heart attacks are the ones you never even look for.